Hello. We'll be recording this session, and this is September 2022, paper 1, question number 10 to 14. All right? Yeah, Happy New Year, guys. I'm recording this video today because I still have 1 hour more to sleep, so why not do some work, correct? So, I hope your new year starts on a very good note. So, let's start. Let's start with the September paper. This is the question number 10. It says a 7-year-old boy. Now, when I say 7-year-old, immediately the things that should pop up in your mind is a tooth, a permanent tooth with an open apex. Okay? Regardless of what the question is about, this is the first image you get because you can clearly answer any question if you can imagine it. So, any question that starts with a 7-year-old boy, you will imagine a permanent tooth with an open apex. Understood? The child complains of pain from his back teeth on both the sides. The pain is worse with sweet foods and cold liquids and persists for several minutes. So, when they are saying the pain is from the teeth, that means something has to do with the tooth itself, it's not the gums or something else. And when they say sweet foods and cold liquids, that means there is some sensitivity as the pain is persisting for several minutes. Tooth brushing with cold water is also painful, but the teeth do not cause pain on biting. The upper six erupted on time, and the child's mother noticed that some of them appeared to crumble as soon as they emerged through the gum. He has neonatal jaundice, good oral hygiene with limited consumption of refined carbohydrates and carbonated beverages. So basically, the diet is good. That is what the question is saying. He has neonatal jaundice. Why is that important? What does neonatal means? Neonatal means at the time of birth. So the question is giving you answer in various ways. See, at the time of birth, the first permanent molars start to calcify. Eruption chart will tell you that. Now, if the child is having some form of a disease and jaundice is a pretty serious one, there is metabolic disturbance, which means that when the calcium, the calcification, and the calcium depositions were happening, there was some disturbance, and that's why a part of the tooth structure did not form properly. That is why both the upper first molars are affected. Now we will see the question. Sorry, I missed. Let me go back to the question. I pressed the wrong key. Okay, we are back to the question. And this is what it is. This is how the tooth looks. You can see the structure of the tooth. It does not look like caries. It looks like the tooth is not formed properly. When this thing happens, what is it called as? It's called as a hypoplasia. Okay, I'm sure you must have seen this. I'm sure you must have read it in the books. So this is a case of classical hypoplasia. So now let's see what are the questions. On the basis of what you know already, what do you suspect? Now they have shared a picture of the upper central incisors and the lower central incisors, and these are the permanent ones. Do you see these white spots? Again, there are the areas where the calcification has not occurred properly. Now, why do we see these white spots? See, uh, the teeth look translucent because the light is reflected evenly from the surface of the tooth if the enamel is properly formed. Now, if the enamel is not calcified in certain areas, then the light is absorbed by the tooth structure as it is more porous, meaning there is more water content in the enamel. And that's why those areas appear opaque, understood, and hence decalcified. So, what is the question asking on the basis of what you know already? What do you know already? That there is hypocalcification. So, out of the options provided, the diagnosis becomes hypoplasia or hypocalcification or hypomineralization. They are all the same terms. So, that becomes your answer. I hope this is clear. Tooth erosion cannot be an answer for obvious reasons. Rampant caries, there is no caries. Can you see caries? And what is rampant caries? Rampant caries is presence of caries approaching in the pulp or involving the pulp, and that in almost all the teeth, which is not true. Dentinogenesis imperfecta. In dentinogenesis imperfecta, all the teeth would be affected, and the color of the teeth would be like very different. This is not dentinogenesis imperfecta. The enamel out here appears pretty much intact, just it's hypocalcified. Now let's go to the next question. Which factor is the least supported to cause such a defect? What is the question? Which factor is least supported? Meaning, which factor is less responsible for this defect? When you see such a question, as explained before, all the following options may be right. Out of all the following options, we have to choose the one which is the least supporting for causing this defect. It's like me asking you, out of your entire family members, who's the person who does the least work? You know, probably it's you. Just a joke. So the options would be probably all of them. You know, your so the family members, all of them would be listed in your options. But then who's doing least amount of work? And if your name is there, then we'll be ticking that, correct? So it's not like the all the options would be wrong. All of them would be correct. Now we have to choose the least one. Now let's come to maternal illness. Yes, maternal illness can cause, it can cause, and there's a major link to it. Now, suppose if the mother was having a lot of alcohol or she had a lot of gestational diabetes, hypertension, or any other thing, this can be caused. Preterm birth, yes, because in preterm birth you are going to be born early, so you're going to be kept in an ICU for a longer time. That may cause this problem. Frequent febrile illnesses, again a metabolic problem, yes. Ear infections, yes. Any sort of infections that would make you take antibiotics or something. Medicines. Now, they have not specified which medicine, you know, but when they say medicine, our mind can directly go to antibiotics, tetracyclines, which can cause. But they have just mentioned medicines. They're very smart people, you know. So, medicine can be anything, no? It can be just a hemoglobin. That won't cause an issue. It can be just any other medicine, so which is harmless, like paracetamol or something. So it does not necessarily say which medicine was given, for what duration it was given. So hence, amongst all this option, medicine becomes the right answer. I hope this is clear. I've given the explanations, please read through that. Now, what investigations are indicated? Intraoral view only, meaning just clinically examination. Of course, that is an investigation that is indicated, but is it like the most important one? You will anyways check and do the clinical examination, but that would be an examination, that won't be an exactly investigation, correct? Panoramic view only. Not a wrong option technically. Occlusal view, occlusal view, you are not going to see much of it. Intraoral and panoramic views. Now, this states both the above two options, so it becomes a comprehensive answer. Actually, the ideal answer should have been intraoral periapical radiographs and panoramic view and intraoral examination. But since that option is not given, I'm going with option C. But in your exam, if this option is given, the periapical view, panoramic, and intraoral examination, then you choose that answer. I hope this is clear, correct? Now, what treatment options are available for the molars? Extraction, not a wrong choice. If the tooth is very grossly destroyed and you think the second molar won't be this much affected, because second molar starts forming when it starts forming after the age of 3 or 4 years. So if the child was healthy, it's gonna come out nice, so it would be a more healthier tooth. So it can shift and drift into the position of 6 or orthodontically repositioned if you choose to extract 6. So it's exactly not a bad option. Have you heard of the term Wilkinson's extraction? That is extraction of the all first permanent molars due to whatever reason, you know. So it's not a bad option. Restoration with composite, you can do it. Yes, you can do it. Full coverage with stainless steel crown. Ideally, this is the option of choice. This you should be doing it, but not all GPs are well versed with stainless steel crowns. But this, I mean, I do a lot of stainless steel crowns in such children, and it works wonders. So that is definitely a treatment of choice. None of the above? No, these are all the treatment of choice. All of the above. Yes, that is the option. All of the above. So for some reason, the candidate who attempted this question chose extraction. No, it's not just extraction. You can do full coverage with stainless steel crown, unless you don't know how to do that. If you don't know how to do that, it's okay. You can refer. This question is very common, and it may be asked you in your ADC Part 2 practical examination. It can be asked. So, in that scenario, if the examiner asks you that can you do stainless steel crowns and you are a GP dentist, then you can tell them, I can't do it, but I can refer you to a pedo. You know, so that is definitely an option of choice. So, here the answer becomes all of the above. Now, which treatment option is the most conservative for the incisors? You remember the picture of the incisors? It had chalky white appearance on the incisal edges. So it is most conservative. Now, whenever an option asks you most best option, it means all of the following options would be correct. But you have to choose the one which is the most conservative. Now, see, it's a 7-year-old boy. Forget the options right now. Don't even bother about it. In a 7-year-old boy, you cannot do any crown cutting. You understand? Because the tooth is not fractured, and you cannot give any emax or porcelain or zirconia crowns because the tooth is still erupting. The occlusion yet needs to be established. Plus, the pulp chambers are really large in size. You will cause massive sensitivity if you go for a porcelain, crown or something. So you definitely cannot do that. The only options you have is to do a restoration, a direct one or an indirect composite restoration, which involves minimum tooth preparation. Minimum tooth preparation is equal to maximum conservation. Understood? So now let's see the option. Full resin composite veneers. Veneer means a complete layer of the cement over the tooth. That's a very possible option. Localized resin composite restoration. Actually, this is also conservative, but then it's not gonna stay, and it's going to, like, it may stay but not for a long duration, and it won't get a full coverage. Plus, the demarcation line of the restoration and the tooth will be seen. Understood? Because when you say most conservative, you do very minimum tooth preparation, and there would be some bulk of the composite that would be there. So if you only cover a part of the chalky white area with the composite, it's going to look very weird because of the margin. It would be very much palpable. Stains will happen. So a full coverage is any day better. Porcelain veneers, like I said, you will not prepare the tooth. Full crown restoration is again a porcelain veneer only. So here the option becomes full resin composite veneers. And aesthetically, it looks really nice. Wow, again I pressed an arrow button. Anyways, let's go back to the same question. I hope all this is very clear, and we have finished SBQ 10. Now coming to SBQ 11. A 22-year-old female presented to the Department of Operative Dentistry complaining of discomfort with the maxillary left premolar during mastication of soft food. Okay, so there is pain. Actually, there is no pain, there is discomfort. Read the word very properly. Discomfort during mastication of soft food. Her medical history revealed no systemic problems. The patient reported that she had suffered a road traffic accident 2 years ago, but with no major trauma to the head region. Alright, so this is the history of the patient. Now let's see the picture. Picture looks pretty decent. Now, which test can be used to exclude the endodontic disease? Very smart question. Basically, this question is saying which test you should do to eliminate that the problem is associated with the pulp of the tooth. See, the patient is saying there is discomfort on biting. Now, when you say there is discomfort on biting, it can be due to wedging of the food between the two teeth. It can be a gingival issue. You understand? It doesn't necessarily have to be because of the tooth. So now how will you know it's because of the gingiva or because of the tooth? So you will check the vitality status of the tooth basically. If the tooth is responding normally, not like a hypersensitive pulp, that means it's not because of the tooth. So basically the question is asking you what test you will do to see if the pulp of the premolar is absolutely normal, meaning this problem that the patient is having is not because of the tooth. So in a simple line they have asked you which test will you do to exclude the endodontic problem. It has to be cold test. The first test that you would do is the cold test. Understood? No symptoms related to sensibility test were present. Meaning you did the sensibility test. So you see the second question gave you the answer of your first question. It means you had to do a pulp sensibility test, which can be only cold test as the gold standard. Then you may progress to other test, but cold test is the gold test. Now, so no symptoms were related. But some pain presented when chewing sweet food. So you took a radiograph. So what can you see? So basically, the question is saying that no extraordinary symptoms were there. That means the tooth was proper. But there was some pain when the patient was chewing sweet food, and you took an X-ray. So now what can you see? When you see the premolar area, honestly, if somebody would show me this X-ray, my first thing, if I know the tooth is not having caries and I can see that on the X-ray that there is no caries, I will start looking at the surrounding areas. My first thing would be to see the lamina dura. The lamina dura pretty much seems intact to me. I don't see any periapical lesion associated anywhere. So if anybody shows me this radiograph, not giving me the background of this question, I would say I cannot see anything abnormal. I see everything is normal. So yes, it can be normal. So you don't have to deliberately go for an answer seeking abnormal. So the answer to this question becomes no significant finding, because there is no significant finding. Now, the patient was asked to bite on a wooden wedge and complained of pain when the biting pressure was released. Now, this is a classic sign of a cracked tooth. The question is feeding you the answer. It is saying it's saying this question is saying that you have done an investigation basically to check a cracked tooth. Now, how do you check it? You check it when you ask the patient to bite on a wooden wedge. Now, when you bite, what happens? The crack in the tooth kind of opens up, and then the liquids between the dentinal tubules are pulled apart, leading to snatching of the odontoblastic process from the pulp chamber, and that causes pain. Have you guys ever understood how pain is caused by movement of the tubules? I think I should show you all some diagrams. You know, it's a very good understanding actually. It's worth investing this time. Odontoblastic process in tooth. I hope I get a good image. If you understand this concept now, a lot of your endo would be cleared and you will understand why and what is happening. Yeah, I think yeah, this is a good image. Yes, let me explain you what this image is about. See, this is dentine. This is the last layer of the dentine, and from here the pulp starts. Now, these are the canals of the dentine, the tubules, and in those tubules, these are the odontoblastic processes. Now, the odontoblastic process, there is a big odontoblast. I'm sure you must have all drawn this in your histology class. You draw a big odontoblast, and there is this nucleus, and there, mitochondria, blah blah stuff, and there is this long process of the odontoblast that goes, and then there is liquid frill, etc around it. Now the important part is near this head of the odontoblast the nerve endings are wrapped around it, and they are lying in peace there. Okay, these are the nerve endings, the yellow one, and then there is blood vessels, etc. But I want you all to focus on the nerve ending. Now, this nerve ending is wrapped around the odontoblasts. Now, what happens when you eat sweet food, or when there is a crack, or when you even blow air after a cavity preparation? The fluid from this area is dragged outside. Now, when it does so, this process, this long arm like thing of the odontoblast is pulled up. When it is pulled up, this head of the odontoblast also gets pulled up. And because this nerve ending is wrapped around this, it gets stretched. It's like you are holding onto something, and that something is dragged outwards, and so your hand gets massively stretched, and that causes pain. Now, if it's a reversible pulpitis, immediately the fluid comes back and the odontoblast comes back in its position. Okay, so the nerve ending goes back to its position, it's not stretched at all, and that's why the pain disappears and it lasts only for a few seconds. Understood? Irreversible pulpitis is a separate thing altogether, so I'm not going into that. Now, in cracked tooth, what happens when the crack opens up? Again, it gets exposed to either sweet or air, and this odontoblastic process is again pulled out, stretching the nerve fiber, causing pain. You know, it's like somebody pulling your hair. So, if somebody is pulling your hair, you will scream until the hair is being pulled, and if somebody leaves it, then immediately you get a relief. This is exactly like this. Get my point? Fair and clear? So now let's go back to the paper. So, so now the patient was asked to bite on a wooden wedge, and now when you bit on it, the crack got exposed, and so it pulled the odontoblastic process, and that caused pain. Periapical lesion cannot be an answer, because if there is a periapical lesion, the pain can be caused just like that. Biting is not necessary for it. Periodontal cyst, that's a separate thing only. It is not exactly related to the tooth, and cyst, you'll have some bulge or some other symptom associated with it. But this test is classically for the tooth crack. Now, trans-elimination showed a fracture line on the occlusal surface. So, you see, the sub-question 4 is giving you the answer of sub-question 3. The sub-question 3 is giving you answer of the sub-question 2 and 1. This question is practically spoon feeding you the answers, like you should be laughing about it. Trans-elimination showed a fracture line on the occlusal surface, but it was not clear whether this crack was causing all the symptoms. Now, what will you do to confirm the diagnosis? Very good question. Think, guys, think. So you did trans-elimination. Nothing was there. Will you start drilling a cavity? Will you start endo treatment directly? Or will you use stainless steel ortho band? Or will you take a bite view? What will you do? What are you thinking? See, the answer should be you drill a cavity. Because when you'll start drilling, you'll start seeing till what extent the fracture line is going. You understand? And after that, once you have identified how big the fracture line is, because the trans-elimination test has shown you that there is a crack tooth, then you may go ahead and put the stainless steel orthoband and do a restoration, or then you can start the endodontic treatment if required. Or sometimes if the crack is just on a portion of a tooth, you can just remove that portion and do a restoration properly. Now, you saw another patient that day with the same condition, but this time there was an orthoband on tooth number 36 for the last 4 weeks, but the pain is still there. Now, what do you have to consider then? See, if the orthoband is already there for last 4 weeks, but the pain is still there, that means the crack has progressed and it's involving the pulp. So removing the band and prescribing analgesis is not a good option, because even if the band of the tooth is there, what will you achieve by prescribing just the analgesics? In fact, removing the band can result in fracture of the tooth. Remove the band and start endodontic treatment. See, starting endodontic treatment is the right option, but if you remove the band and then you start doing a root canal, the vibrations from your drill is going to cause the tooth to fracture. It may cause the tooth to fracture, not necessarily it will cause, but it can cause. So actually, you are doing more damage to the tooth. Leave the band in place and start endodontic treatment is the right option, because the band is going to secure the boundaries of the tooth and is going to hold in place while you remove the pulp. You have to remove the pulp because the crack is going in the pulp, and because it's going in the pulp, it's constantly being exposed to the outside environment, and eventually it will cause more and more pain. So the pulp removal becomes mandatory, and then you can put a restoration and a crown on top of the tooth. Extract the tooth, not a bad option, but is it conservative? No, it is not. So you can extract the tooth if the patient would like it, but then as a dentist, if you would like to save the tooth and you have the option of doing the root canal, then that should become your answer of choice. I hope this is clear. Correct? So now we finish SBQ 12 also. Let's move on to the SBQ 13. Where is our SBQ 13? I hope your concepts are getting more and more clear as I'm solving the questions. Now SBQ 12. Patient with lactose intolerant and dairy allergy with self-induced vomiting. Okay, self-induced vomiting meaning what? The patient is having bulimia nervosa. Self-induced vomiting is also means that there you can expect a question on erosion of the teeth from the palatal side. Plus the patient is lactose intolerant and dairy allergy. This is very important, don't forget this, because when they say dairy allergy, that means expect a question where they are going to ask you whether we can apply something on the tooth which has calcium, and you might think yes, let's go with that, there is erosion of the teeth, but you forget that the patient was having dairy allergy, and if you prescribe something which is having calcium, then you're in a big problem. Now, she was visiting psychologist for this condition who was trying various therapies but without success. So she is basically not having success with the psychologist. Alright. Now, which teeth surfaces are most affected in vomiting? See, vomit comes from inside the body. So the palatal surfaces of most of the teeth and the occlusal surfaces would be affected of the molars. Now here they have not given the option of palatal surface of the incisors. They have given palatal surface of maxillary posterior, which can also be a correct answer, but maxilla again, in the order of my priority, the vomit is most likely to touch my lower teeth than so much of the upper teeth. So if mandibular incisors, lingual was the option now, I would have chosen that as my first option. But since that is not there, then my next best option becomes the palatal surface of the maxillary posterior, mandibular posterior, sorry. But even that option is not there. So then I will choose the occlusal surface of the mandibular posterior. So this is my hierarchy. Technically, all the surfaces would be affected, but the most affected, it's asking us. See the question. It's most affected. So then I proceed to. Dentist wanted to prescribe calcium supplements for remineralization. What can be done? See, I told you about this question even without coming to this question. Because when they mention some history about the patient, it's not for increasing the sentences in the question. It means they are going to ask you sub questions about it, okay? And they have given you a hint, so you don't forget. If you forget, then you are doing a silly mistake. So if the question has mentioned the patient has dairy allergy, meaning he has allergy to calcium. Now patient wanted to prescribe calcium supplements. Now what can be done? Get calcium over the counter? No. GC tooth mousse? No. Calcium rich food? No. Refer her dietitian for a diet plan? Not a bad option, but dietitian is dietitian, it's not exactly a doctor. Refer to GP for bone density scan before prescribing calcium. Yeah, actually this is also a very vague option. Ideal option should have been referred to GP and then take the consent and do the allergy testing as to if they are allergic to the calcium supplement that you are going to prescribe. So that should have been the ideal answer. But then, since the only best option given in this question is this, and that is what I could gather from the candidates, I'm going with this option. But in the exam, if at all they change the options and tell you refer to GP to see the allergic testing of the calcium, then you go with that. Understood? Now, what will you advise her regarding her condition? Brush your teeth immediately after vomit to remove acidic materials off it. Well, it's going to make your teeth and mouth feel nice, but doing so would further degrade your teeth, so you cannot get this option. Use antacid. Even if the patient chooses to, use antacid, but still she has a psychological problem, you see, so she is still going to try and vomit out that also. So the best option that we can give her the advice as avoid brushing for at least 30 minutes. Like rinse your mouth with water, but don't brush immediately after you vomit because there would be still a lot of acids and you would practically erode more of your teeth structure. Now, how to protect her teeth chemically against acid challenge. Use antacid to neutralize acids before vomit, better than rinsing with water after vomit. You can't do that because even if you're giving antacid, she's still going to vomit because, like I said, she's having a psychological condition, so it's no point. Now, as a practical solution, add calcium, magnesium, phosphates, or fluorides to beverages to reduce their erosive potential. Can do that, but again, would it protect the teeth so much? No. Self-application of fluoride gels in the evenings for nocturnal reflux. Well, out of all the options, I mean, both the above options are not technically completely wrong, but out of all the options, option C is more better option because, see, she is going to vomit anyways. So if you're going to apply fluoride before, it will actually give a lamination layer over the tooth. It forms fluorapatite crystals. Fluorapatite crystals are very strong, resistant to acids compared to the normal hydroxyapatite crystals. So it's a good decision to apply the fluoride gel in the evening for nocturnal reflex. Okay, we move on. High risk group of erosion is elderly, teenage, children, adults. Uh, See, not all teenagers can have bulimia nervosa. They can have, but not all of them. A lot of adults can have, but not all of them again. Elderly, yes, true. Why? Because, first of all, age, somebody eating for 50, 60 years is more prone to having teeth problems than somebody who's just like a 10-year-old or a 20-year-old, related to the age. Hence, elderly, and also because as you age, saliva quantity decreases, the water consumption decreases, so there are more acids in the mouth, the saliva becomes a little acidic. All the other age related problems are there. You take more medications for a lot of other issues, you have stress sometimes, so anything can happen. So age is a very confounding factor, as in it's a very confusing factor. It creates a lot of problems. That's why people are afraid of aging, in general. So yeah, high risk group for erosion is elderly, for attrition also, for abrasion also, everything. The high risk group is elderly. Now SBQ 13. Wow, so we finished 10, 11, 12, 13. This is the fourth SBQ for today, and then I'll be doing the 14th SBQ, which will be the last, and thereby we'll finish off the paper. Okay. I hope so far things are clear. If you're getting very saturated with the explanations, because I know it's quite a lot, you can take a break, pause this video, take a break for 4-5 minutes, relax, come back with a new, fresh mindset, because it gets daunting. But the good thing is that your concepts will be getting more and more clear. Your analyzing skill for the question is going to get more and more clear. So, there about it. Now, this patient is a 6-year-old boy with an erupting first permanent molar. Again, 6-year-old, meaning you will imagine a tooth like this with an open apex. That is the image should come. Like how if I say Lionel Messi, the image of a footballer with the striped Argentina flag color t-shirt comes in your mind. Same thing, a tooth with an open apex should just directly pop up in your head. Classify the caries in the first primary molar. Guys, I've given you the classification of EGDAS, right? I told you all to read that chart once in every 10 days. Do you know what is EGDAS classification? ICDAS. Caries into enamel, grade 1. Caries crossing enamel into the dentine, grade 2. Caries in the inner one-third of the dentine, grade 3. Crossing two-thirds of the inner dentine, grade 4. Approaching the pulp, grade 5. Correct? Remember? If not, open that chart. After you open that chart, now see the picture. Now in this picture, this is like almost involving the pulp, and this is like just a bit away from the pulp. A thin layer of dentine is still visible here. The caries is practically inside the pulp. So now what are they saying? In the first primary molar, this first primary molar. Now according to the picture that you see, this is grade 5. Understood? What caries sequela must we be avoiding in this situation, in the question 1 situation? See, what caries sequela must we avoid? Now in primary teeth, when the caries occurs, the first thing that it does is pain. Secondly, the caries can go, and because the bifurcation area of the pulp is very thin and there are many lateral canals coming from the bifurcation area, and the trunk of the tooth is very small. Do you know what is the trunk of a tooth? This area. You see this thin area? This is called as a trunk of the tooth. Now in permanent teeth, this is pretty thick. But in primary teeth, this bifurcation area is very thin. So when caries occurs and the pulp gets inflamed, and there are many lateral canals out here, the inflammation spreads and it starts resorbing the bone out here as the inflammation spreads through these lateral canals in the bone. And if this area breaks, then you have to extract. Then you can't do a root canal. So the primary thing that we have to avoid once we start seeing a cavity here is, of course, pain. But after that, we don't want this tooth to fracture. So that is what the question is asking you. So this is what we have to avoid. Primary tooth abscess in the bifurcation area. Mobility, Turner's enamel are all later things. So if here the option was pain and loss of tooth, I would go with that option. But since I don't have an option here, then I would go with this primary tooth abscess in the bifurcation area. Now when will the first primary molar exfoliate? Guys, eruption chart. You must read that. The answer is 10. Best management at this stage. Leave and observe? No, not at all. Why? Because it's approaching pulp. It's caused a frank cavity. There is destruction of the inner two-third layer of the dentine. And the child is just 6-year-old. And the tooth is going to exfoliate at the age of 10. So there are 4 more years. In these 4 years, if you don't do anything, definitely problems are going to happen. So the answer is filling if there is no pulp exposure. You can extract if the parent wants that, but if filling is an option, then why not that? Now another patient who is under consideration for preventive treatment, which one surface would you not seal as the only treatment? Why? Okay, what is the question? Another patient. So we are no longer talking about this patient. Another patient who is under consideration for preventive treatment. What is preventive treatment? Preventive treatment is fluoride varnish and pit and fissure sealants. Now, which one of the surface would you not seal as the only treatment and why? So, what the question is saying after presenting you with this bite wing is, in which tooth you will not do pit and fissure sealant? Will you do on this tooth? Yes, because you don't see any caries. So pit and fissure. What are pit and fissure sealant, guys? Pit and fissure sealants are thin layer of sealant over a tooth structure with a deep fissure, which is not having a cavity, because you're not drilling any tooth structure. You are just cleaning, etching, and putting a sealant in the fissure. If there was a deep cavity, you cannot do etchant and sealant without removing that caries. Understood? So this is what the question is asking you, that which of the teeth amongst these will you not do a sealant, and why is that? So you will do a sealant on this, this and this, but you won't do on this because you can see a cavity here. So what you have to do here is a proper restoration. Understood? So this becomes your answer. That is a lower first molar. I hope this is clear. You may get confused with the question, but if you read properly, you will slowly understand what I'm trying to say. Now a 33, okay, now yeah, so wow, we finished SBQ 13. Quite a while, almost like 40-50 minutes it takes to solve. Let me have a sip of water before I proceed to SBQ 14. Okay, before I proceed, I just want to go back to one question because I realized that I have marked one answer here and I have given another explanation. But let me explain you that both options are correct. This question. Trans elimination showed a fracture line on the occlusal surface, but it was not clear whether this crack was causing all of the symptoms. So what you do to confirm the diagnosis? I know I said drill a cavity, which is the correct answer. See, use of stainless steel orthoband is also a correct answer. But if you just put the stainless steel band and then you wait and see that if the patient now bites and then there is no pain, then probably your problem is solved. But can you leave the stainless steel band forever? You can't. You'll have to give a full coverage restoration eventually. So let me simplify this for you so that you're not confused. Since the question is asking what do you do to confirm the diagnosis, you can go with using the stainless steel orthoband, because once you put the stainless steel orthoband and then you ask the patient to bite, and if the cracked line is not exposed, then the patient will not have pain, which pretty much means that it was because of a cracked tooth only. But if this option is not given, then you drill a cavity. Okay, so I correct my answer here because it makes more sense. But drill a cavity is the answer of choice if stainless steel orthoband is not given. So if the question is rephrased and saying what would you do for the treatment options, then you start drilling a cavity. But since this question is saying what to do to confirm the diagnosis, no? Confirm the diagnosis doesn't require me to drill a cavity. So then I would go with the use of stainless steel orthoband. So basically, you have diagnosed with the trans illumination that there was a cracked tooth, and but you still want to double confirm your diagnosis basically. So what you do is you put a stainless steel orthoband. Now when you put a stainless steel orthoband, even if the patient bites on it, the tooth segments cannot be separated, so the crack line will not be exposed and it would be bounded by the stainless steel orthoband. So then you put a stainless steel orthoband and you again ask the patient to bite on the wooden wedge. So now when the patient bites, he says, oh, there is no pain. you know so if there is no pain after you have put the stainless steel band, that means the pain was because of this tooth only. So this question is basically asking you to double confirm your diagnosis. So to confirm the diagnosis, putting a stainless steel orthoband is fine. But if the question was telling you what would you do next now that you have confirmed the diagnosis, then the answer is drill a cavity. You understand? Then you drill a cavity to see the extent of the crack of the tooth, and once you have seen that, then you put the orthodontic band and then you do the restoration or the root canal, whatever. Getting my point? So this should be the answer. But if the question was saying that the crack was involving the pulp and you have to immediately start a root canal, not drill a cavity just for the restoration, in that scenario you will put the orthoband first because you know you are going to do a root canal. And to do a root canal, you have to destroy a lot of tooth structure for doing the RCU. In that scenario, you would put the orthodontic band, then you start drilling a cavity. But for just a restorative purpose, first you will drill a cavity to see the extent of the crack, to see if it's actually going in the pulp or not. So all depends on the phrasing of the question. I hope this is clear. If this is not clear, you will message me and I will again send you the explanation. So I correct my answer for this question. To confirm the diagnosis, I will put a stainless steel orthodontic band. If I have confirmed my diagnosis and the question is telling me what I will do next, as the patient is having only occasional pain, then I would drill a cavity to see the extent of the fracture. If the question is saying the patient is having pain irrespective and it's in the pulp and there is a crack in the tooth and you have to start the root canal treatment, then my option would be put the orthoband, do the root canal, and then do the core and the crown. I hope this is very clear. Now we move on to the SBQ 14. Okay, the last SBQ for today, and thereby we finish off the paper 14. Well, a 33-year-old Aboriginal female. What is Aboriginal, guys? Aboriginal means the old natives of Australia. Now, when you say old natives of Australia, meaning they can have a rheumatic heart condition, which means some kind of prophylaxis antibiotics is there. Because this is how you should link in your mind. Maybe the question may not be asking you about the antibiotics, but when I say Aboriginal, you should immediately imagine a very old tribe of Australia and who live in villages and who have a rheumatic heart condition probably and would be having some other form of heart condition which will require an antibiotic prophylaxis, and probably they wouldn't know how to speak properly the English language. They may have their own native language. Understood? So now a 33-year-old, 33 is pretty young actually. Now she cannot talk English, the question is mentioning. Presented at your clinic with her 14-year-old son who can speak English. Okay. Now the patient complained of tooth pain which was excruciating. Excruciating means sharp shooting. And swelling in the lower right posterior region. Okay. She has not been to a dentist for many years. That means not a regular dentist, a dental patient. That means you may have to do something in a single visit as she may not come back again. Intraoral examination showed a large polypoid lesion of about 1.5 centimeter by 1.5 centimeter with a 2 diameter stalk protruding from the carious cavity of 4-6. Okay, you might just jump onto the diagnosis of hyperplastic pulpitis, but if the question has taken this much effort to tell you that there is a lesion with a 2 of diameter stalk, that means the question wants you to do something about the lesion and diagnose it. Now, when they are mentioning this kind of diagnosis, you have to straight away not give a diagnosis, okay, unless the question is asking you. Your first option should be, let's see what this is in biopsy. I know 99% it would be hypoplastic pulpitis, in which case, biopsy is not required. But you have to be very safe in practicing. So you have to tell the patient, there is a lesion and probably looks like a harmless one, but I have to just confirm the diagnosis irrespective of it. Now, pulpal growth was pale pink in color and was covering the entire cavity in relation to 4-6. She has no missing teeth or carious teeth other than this tooth. So basically, only this tooth is having a problem. No other tooth is having a problem. That means her oral hygiene must be pretty okay. Now, how to proceed with investigation of patient's complaint? You don't treat the patient until you find a translator. Now, since she's come with a 14-year-old and this patient can understand English, you can speak to a 14-year-old and you can rely on him to translate things to the mother. So the rest of the options are not bad exactly, but this is a very good option. Because you are just doing the investigation and you can tell the child that I'm going to do this, and once the patient understands and nods the head and understands what you're trying to do, because you're just doing investigations, it's all right. What is your diagnosis? Now, my diagnosis is hyperplastic pulpitis. Necrotic pulp is not my diagnosis because I can see this huge pulpal tissue coming out, classic signs of hyperplastic pulpitis. What is the appropriate management? Well, remove the tissue, send for biopsy, and commence RCT because 99% your diagnosis has it. Do nothing and wait for biopsy result is not a bad option, but what does the question mention? The patient is having excruciating pain. So you have to do some pain management. But at the same time, You don't want to discard the tissue, you have to be on the safer side, so you will send for biopsy. Because the patient is in pain, you have to do something. So you cannot do nothing. You understand? You have to do something. You cannot do nothing. Extraction, not a bad option, but what is the question asking? Appropriate management. Understood? So appropriate management means you want to save the tooth if you can, because the x-ray shows the roots are pretty nice. You see this x-ray? The roots are pretty nice and you can do a root canal treatment, so why not? The patient has a history of rheumatic heart disease. What is the appropriate antibiotic prophylaxis? Wow, look at this. See, whenever the question says aboriginal, they will ask you about antibiotic prophylaxis. Like, I just took a chance saying that, but this question is still asking for it. So they will ask you. That's their way of asking a question, trying to link a basic dental question to this. It also tests your knowledge about, after all, you're going to practice in Australia because ADC thinks you're giving the exam so that you can practice in Australia. So they want you to know about their people, their culture, the common problems that the people can have. So now that you know aboriginals can have a lot of heart problems, you will ask them, do you have a heart condition? Which normally you wouldn't ask a normal person. So that's good. So, which is the prophylaxis of antibiotic that you're going to give, and which is the appropriate one? When they use this adjective appropriate, meaning all the below options will be correct. You have to choose best option. See, you are a dentist. You don't give intravenous or IM medicines. You want to give oral if the patient is healthy. So, when I say oral, I definitely eliminate the option D. Clindamycin, not bad, but I would give that if my patient was allergic to penicillin. Penicillin always becomes my first option of choice. Amoxicillin, 500 milligram, 8 hour for 5 days. Say, you know what is the dose of antibiotic prophylaxis for penicillin? It is 50 milligram per kg. So, example, if the patient is, say, 50 kilos, so 50 into 50 becomes what? 2500 milligram, which is 2.5 grams. A 33-year-old female would definitely be around 50 kgs. Or max, or rather minimum 45 kgs. She cannot be thinner than that. Then she would be malnourished, and then that would be a problem. So a 33-year-old female would be minimum 50 kgs, and my max dose becomes 50 milligram per kg. So I can give 2 grams. 500 milligrams becomes too less. Plus, what is prophylaxis? Prophylaxis meaning you just give one dose before the procedure. You don't have to give for 5 days. So, if one of the options was amoxicillin 2 gram 1 hour before the procedure and for 5 days, don't get confused. It's a prophylaxis. Only one dose before the procedure is fair enough. So, the dose matters and the duration matters. So, the answer should be amoxicillin 2 gram 1 hour before the procedure, okay? A pulp polyp resulted from. Pulp polyp is chronic hyperplastic pulpitis, basically. Chronic, the term chronic means long standing. So, see how nicely the options are presented. They have not mentioned anywhere the word as chronic, they have mentioned long standing. They love to use synonyms to confuse you. Basically, they are testing your English vocabulary. I know this is not an IELTS test, but still, they want to test your English vocabulary. So, first of all, it's chronic means it's long standing. It's not a high grade, it's a low grade infection. I mean, the diagnosis that we have learned, the pathology of the pulpal problems, chronic hyperplastic pulpitis is always a low grade pulpal inflammation in a young patient, which is what it is. Hence, the answer becomes long standing, low grade irritation. So, I hope this is clear, and we have finished the entire September 2022 paper. I will soon be uploading the link on the YouTube, and I'm going to make it unlisted. So only people whom I share the link with will get the answer and the recording of it. All right. So if there is any question, any doubts regarding any of my explanation, just leave me a message and I will come back to you. So have a good night and happy New Year.